Good morning, everyone. My name is Narda Apakchi. I'm the Vice President of Policy with the SCAN Foundation, and really excited to be here today on this webinar about the LTSS state scorecard and California insights and opportunities. The SCAN Foundation has supported the development and the release of the scorecard since its inception, really since 2009. And it was really created to answer calls for better ways to understand how LTSS systems are meeting the needs of older adults all across the country. Since the first scorecard in 2011, we've seen state leaders, advocates, policymakers, others really use its data to advance programs, policies to improve systems of care. Now we're in the fifth iteration, and the scorecard really remains the only tool offering that comprehensive analysis of LTSS performance across states. The 2023 scorecard introduced new changes, including updates to the framework, a new methodology for factoring equity into performance, and providing states with innovation points for certain efforts to improve LTSS. We're incredibly excited to partner with the California Collaborative for LTSS, as well as AARP California, on this virtual policy forum and really dive into the insights from this most recent scorecard and what that means for the state of California. We'll start with a brief overview of the services that encompass LTSS. We'll hear a summary of the scorecard results, hear perspectives from advocates in the field, as well as hearing from state leadership on initiatives to continue to improve LTSS. And after the state panel, we'll have 15 minutes for a Q&A session, and we'll close with some remarks from Kim McCoy-Wade, the Senior Advisor on Aging, Disability, and Alzheimer's from the Office of the Governor. I'm going to go through just some quick housekeeping items before turning it over to Maria Kalina with the California Collaborative for an overview of LTSS. So just noting that this session is being recorded. So the recording and materials will be shared with the folks who have registered after the webinar. Closed captioning is available. Please enable captions by selecting the transcript icon from your toolbar. The chat will be open throughout the duration of the webinar, and a reminder just to keep your comments respectful, and that we are saving time for Q&A. So just select the Q&A icon on your toolbar to submit questions at any time, and please be sure to indicate which panelist your question is intended to go to. So with that, I will turn it over to Maria.
Thank you so much, Narda. Thanks for that wonderful introduction, and welcome to everybody who's joining us today. Really excited that you could be with us for this webinar. I have a pretty tough job, which is to explain long-term services and supports in 5 minutes or less, and I'm really hoping to keep it to less than 5 minutes so that we can get on and hear from our esteemed panelists. So what are long-term services and supports, sometimes referred to as LTSS for short? LTSS encompasses a wide range of personal, medical, and social supports needed by individuals with functional limitations over an extended period of time. LTSS is inclusive of supports in the home and in the community, also known as home and community-based services, or HCBS. I know we've heard that term a lot lately, as well as facility-based care like nursing home care and intermediate care facilities. I think it's important to recognize that not everyone is able to live at home and in the community, but for individuals with lower needs levels, a robust network of HCBS programs helps individuals avoid unnecessary and more costly institutionalized care. For those with chronic conditions that impact their activities of daily living, or individuals with functional limitations, these programs enable them to live a full and rich life. Some examples include personal care, support with bathing and toileting, transportation, rides to appointments, institutions of faith, libraries, care coordination, developing and managing care plans, meal prep, having someone prepare meals for you, grocery shopping, wound care, housekeeping, running errands, medication management, exercise, participation in social programs that address isolation. And all of these can be provided in a range of settings. Home-based care, you can have a personal care aide or a home health aide, respite care, having a caregiver, In the community, there's assisted living facilities, adult day health centers, respite care again can be provided in a community setting, senior centers. We have a network of villages in California. And then lastly, facility-based care, including nursing homes. So these are really kind of a wide range of programs, and LTSS is that umbrella term that includes both community and home-based programs as well as institutionalized care. And I think I'll pause there, but if anybody would like to get into the weeds of LTSS, give me a call. We'll set up a time, we can walk through it together. And with that, I think I am passing it off to Nina.
So good morning, everybody. I am Nina Weiler-Harwell with AARP California. I guess we could advance the slides a bit. And I am an associate director for advocacy and community engagement. I've actually been with AARP, yeah, I am proud to say this, 26 years. My role here, I'm our AARP issue expert on caregiving and long-term supports and services. And I've also served on several master plan committees, I think a total of 4 MPA related committees. If you could skip ahead a couple of slides and I'll jump right in. So this is just kind of an overview of where we're headed for the next 14 minutes. We'll be looking very high level at California's overall ranking. Look at some of the dimensions. Those are the topic areas and indicators, which are actually individual measurements of high performance, along with those areas where California could improve. I will not be going into every indicator or every dimension. There'll be lots of opportunity to discuss additional dimensions and indicators as we go through. So I just want to make sure you're all clear that it is, my goal today is not to be encyclopedic. If we could move ahead, we'll get into our ranking. So California did rank 11th overall in this year's scorecard. And you can see the different dimensions that I had mentioned before, the kind of general topic areas that the scorecard measures. And we did really well in some areas and not as well in some other areas. I will dive into that for a bit, but just hitting an area that certainly needs improvement is community integration, which I won't have a slide on this, but we'll cover the challenges that California has with affordable housing and transportation for individuals. And then another area where we do well having to do with choice of setting and provider. If we can move on. So I'm jumping right into our areas of high performance. First of all, according to the scorecard, the Medicaid HCBS spending or rebalancing indicator, California, I keep saying AARP when I mean California. California showed up extremely well. According to the measurements in the scorecard, over 83% of spending on older people, adults with disabilities went to home and community-based services. Our ranking was number 1. And just to compare to the general, the state of the country, the national percentage was just 53%. So while things were certainly not perfect, California did really well in this area. Moving on to the next indicator, we did want to highlight that the master plan for aging has a new, as noted, kind of a new framework, and one of those pieces is a multi-sector plan on aging innovation point. So California got that innovation point. A multi-sector plan on aging is defined in the scorecard, but among every other things, includes the leadership of either the governor or his or her administration, and it must be a 10-year plan, among other things. We were only one of 3 states to qualify for this innovation point. Moving on to the next indicator. Well, this is actually, the indicator of choice of setting and provider, which I had actually highlighted. This is a specific indicator, and this has to do with the number of people who receive long-term supports and services through self-directed programs. Once again, California is #1 in this dimension, and that is thanks to our wonderful in-home supportive services program, IHSS. In 2020, the last time we received, the last time we had a scorecard, California was also #1 in this area. Continuing on, an area of high performance, and I will also include it in areas for opportunities for improvement, is supports for family caregivers. Within that dimension, there's a grouping of 12 different indicators that really show the existence of policies to support family caregivers. Our ranking overall is 15. And as we'll see later on, why that is. But we did receive credit or partial credit for 8 indicators, which included the existence of our paid family leave program and our paid sick leave program, which this won't be in the scorecard, but paid sick leave was just expanded to 5 days. Moving on, areas now for improvement, and we have a few. And again, I just want to reiterate, I'm not touching on all indicators or dimensions today, but affordability and access remains a real challenge for California. And this slide lays out the cost of nursing care, home care. There are other indicators within the scorecard. They are simply out of reach for the average 65 plus couple. It's completely unaffordable for most people. So only less than 4% of Californians generally have purchased long-term care insurance. Anyone who's worked with me over the last few years heard me mention a figure of 4.2%. Unfortunately, that went down some more. And this particular area really shows we have a lot of work to do to help not just the missing middle, not just upper middle class folks that are struggling as well, but individuals who are near Medi-Cal eligibility, share of cost individuals. These are absolutely unattainable figures for the vast majority of older Californians. Moving on, other opportunities for improvement include supports for family caregivers. So I did highlight some of the good things in the scorecard regarding California's the areas where we do well under supports for family caregivers. But we're also looking to other measures. That includes the existence of a caregiver tax credit, which unfortunately California does not have. We have been attempting to pass a legislation to give family caregivers protected status for the purpose of employment. Also an area where we have opportunities for improvement. And finally, nurse delegation. So the number of tasks that can be delegated has actually increased. I believe it was 16 in 2020. It's now 22. And California has been pretty flat in that area. So we're still only allowing 3 of 22 tasks to be delegated to a family caregiver by an RN, by a registered nurse. Next slide. I'm going to highlight the Aging and Disability Resource Centers. And the reason is, this is certainly an opportunity, but we do want to highlight that California made significant strides just in the last few years in terms of standing up a fully functional aging and disability resource connections / no wrong door system. And we know that through the master plan, there's lots of work happening. In 2020, California ranked number 50. We are now, our ranking has improved. It's now 47. And again, we're starting to see some progress here. And, you know, I think it's fair to say that the ongoing efforts through the master plan for aging should lead to additional improvements in future scorecards. Moving on. And this is really my closing slide. So I'm just hitting a few indicators that I didn't get into a lot of detail on before, where we definitely, there are definite opportunities for improvement on the scorecard. First of all, the percentage of nursing home residents with low care needs actually rose from 2020. The California scorecard ranking is 26. And I would also add to this that if you look at the equity measures, if you have a copy of the scorecard, you will notice that the nursing home residents that are more likely to be to not be transitioned back to the community despite low care needs is actually the community that is most impacted by this are Black Californians. So we have absolute work to do there. Our direct care worker wage competitiveness, this is a new measure. As you can see, we didn't rank so well. It will remain to be seen whether the new laws that have just been passed, increasing both fast food worker wages as well as healthcare worker wages over time, do in fact improve California's standing in this particular indicator. And finally, successful discharge to the community from a nursing home. Certainly work is needed there. We are in the bottom half of all states in terms of our ranking on this measure. Maria, I think that's my last slide. So thank you.
It is, and thank you, Nina. And I'm going to turn it over to Hagar.
Thanks, Maria. My name is Hagar Dickman. I'm a senior attorney at Justice and Aging, and I'm going to just do a quick introduction for our panelists today for the stakeholder group. First, I'd like to introduce Dr. Donna Benton. She is the director of the USC Family Caregiver Support Center, is a research associate professor of gerontology and director of family at the USC Leonard Davis School of Gerontology. She's a member of the California Coalition for Family Caregiving, Work Family Coalition, and Elder Justice Coalition, and works on the Master Plan for Aging. Carolyn Nava is the Community Relations Director with the Disability Action Center and Disability Action Network Coalition Chair. She assists DAC with advocacy, program development, grant administration, and writing. Carolyn also serves on several boards and committees, including California Collaborative for Long-Term Services and Supports, North Valley Housing Trust, Older Adults Policy Council, the Statewide Access and Functional Needs Advisory Council, and the State of California Healthcare Affordability Advisory Committee. Next, we have Megan Rose. She is the General Counsel and Chief Government Affairs Officer for Leading Age California, an association representing over 700 nonprofit providers of housing, care, and services for older adults across the state. In her 10 years with Leading Age California, Megan has worked to expand access to affordable housing and healthcare for low-income older adults through legislative and regulatory advocacy. Sawait Sayom works on state and government policy advocacy for Disability Rights California, where she advocates on issues related to healthcare, long-term services and supports, home and community-based services, including IHSS, and other human services related issues. And we just heard from Nina, and Nina works at AARP, and she introduced herself, so we'll go from there. So the first question I have for you to get us started, as we just heard from Nina, California ranks number 11 overall in the LTSS scorecard and ranks first in rebalancing institutional spending to home and community-based spending, and has a few areas of strength like the choice of settings and providers. But the state ranks 31st in community integration and 30th for affordability and livability. And I'm hoping, Sawai, maybe you can start us off by talking about the discrepancy between the state's ranking on choice of setting and community integration, and what that means for the individuals that DRC serves.
Absolutely. Good morning. Thank you, Hagar. And it's great to see everyone today. Yeah, no doubt, I think that, the data is alarming on what you just shared, Hagar. And I think, I think that here at DRC, and I think we can all agree to this, that the COVID pandemic really highlighted, the concerns that exist, the huge disparities that also exist for livability and affordability. And I think that the work that we have been doing at DRC, we continue, I think we continue to see advancements, but as we make advancements, it's that we realize that there's so much more work to do. And I think the pandemic highlighted that. And I think that it's also the case that perhaps, we don't even have a full picture of the impact, right, that the pandemic had on our state, nation, and so on and so forth. But what I would say is that, we were very obviously disappointed to see, the data, the results, but can't say shocked, right? I think that our advocacy continues to support or is in alignment with what the scorecard revealed, Hagar.
Thank you. Donna, is somebody who's really working on caregiver issues, can you kind of supplement what Sawide is talking about as far as the services and talk about what supports caregivers you think would need in California in order to really bolster both their ranking for how California is doing with family caregiving and also the support that they provide recipients of care?
Yeah, thank you so much. Looking at what we have currently, California, we're doing pretty well for caregivers, but there are really key things that we are missing. And I think some of that might have to do with how we can have a more equitable system for family caregivers. And when I'm looking at equity, we need to look at cultural equity, we need to look at race, we need to look at geographic equity, and also financial equity. So within California, some of the things that were mentioned, we still need to help family caregivers with things like what we weren't able to pass, which is things like caregivers being able to have family responsibilities without fear of not being employed or of losing their jobs. And this is really an equity issue because much of this family caregiving often falls within minority communities, rural areas where they may not easily access the few resources that are there. So even as we improve resources, if we don't improve them for these cultural and ethnic and rural communities, we're going to have trouble and we'll still have problems for our family caregivers. We need to continue, while we've improved in terms of helping caregivers with taking time off. In California, I think that'll show in terms of having 5 days for family caregivers. But when we look at it through an equity lens, we still need to be able to have caregivers who within families can take off for more than one person at a time, because sometimes it requires multiple caregivers at the same time. Within some families, we need to continue to expand the definition for family caregivers so that we can continue to allow for chosen family, because as our aging population continues, there will not be enough what we call traditional family structures. And we also have a wide variety of people in different family structures, from LGBT communities and immigrant communities, where it's very important that we're able to give back to those people who cared for us, and they may not be blood relatives. So I think that those are things that we want to look for, along with that flexibility. And I think what Nina did emphasize, which is that nurse delegation. We're asking family members to do all of these very complicated tasks, and yet the story, if you think about it, how hard is it when you're working and then you have to go home to give somebody some medication because the person that you've hired can't give that person an aspirin? That's time off, and it makes it much more difficult, and it doesn't allow for flexibility. So I'll leave it there, but I want to, just underscore all of those things. And so thank you very much.
I'm glad you brought up the equity lens here because I think it's such an important part of the scorecard. And I think maybe Carolyn, if you don't mind talking about how you see that playing out in the northern rural California communities, what the equity issues are there, and how are the issues in the scorecard different, do you think, in your communities versus the more urban areas of the state?
It's interesting, Hagar, because when we were rehearsing for this, I thought you could spend a whole day just on this one concern. So I'll be as brief as I possibly can to hit those impact areas. And I think first we have to start by defining Northern California in comparison to what we're looking at with something like a broad national livability index, because with Northern California, there were 3 major cities that made the top 100 cut. 4 actually, the Alameda region, Berkeley, San Jose, San Mateo. Those are all very large cities in what we call metropolitan or municipal Northern California. So I'm going to take you north of all of that even farther. I'm going to take you 3 to 4 hours north, because California is a very long state. So if you were looking at a map, think of the L shape of California and go above the corner of the L. That's my territory. That's where the Disability Action Center romps and the Diversability Advocacy Network calls home. Now in that region, the picture is very different. We're looking at much smaller populations, an average of anywhere from 3 to 14 people per square mile. So often resources just are non-existent because the population isn't here to support it. Higher rates of unemployment. Butte County, my home, has the highest unemployment rate in Northern California, or in California, the state rather. So healthcare also changed with the pandemic. We all faced all of this: technology turnover, people turnover, more outsourcing, financial strains. But in the north, with these rural populations, we're talking about 16 of our clinics at risk or likely shutting down over the next 8 to 12 months. We've already lost primary care physicians, which means most of us travel 1 to 3 hours south to Sacramento just for a primary care physician or to see a dental specialist. So it's a very different picture, not to undermine what's been accomplished by these surveys and studies. It's just that it's important to take that lens closer in order to begin to make that impact where equity and inequities come into play.
Oh, I'm mute. Thank you, Carolyn. And maybe Megan, you can take this a little bit further. I know that you're really thinking about the affordability and livability index, and I'm hoping you can talk, maybe take Carolyn's perspective and maybe take it further to statewide and talk about that low ranking of 30th for livability and affordability. What do you think accounts for the ranking? I mean, obviously we have high prices, but in the context of LTSS, of long-term services and supports, and where are the most impactful investments that you think the state can make in order to move us in the right direction?
Sure. Well, we all say that housing is the foundation for LTSS, right? It's really hard to enter our long-term care continuum if you don't have a place to live. I think California received a low ranking because we have a housing crisis. I mean, it's evident. We are consistently ranked worst among the 50 states for housing cost. We just have a huge housing shortage that is driving our costs up. I think we are 1.3 million affordable units short of where we need to be to house everyone in the state who qualifies for affordable housing. And I think that older adults and people with disabilities who live on fixed incomes have been disproportionately impacted by this housing crisis. I think the fair market rent in California for a studio apartment is $1,600. And the average SSI payment is $1,100. So, I mean, you do the math, it's just impossible, literally impossible for some people, a lot of people, to live in California. And so when you don't have a home, it makes it very difficult to access LTSS. And so I think that that's that's a really, really big barrier. And the state is working to increase production of affordable housing, and to move more money into addressing our growing homelessness. But I think that we've not really paid enough attention to the kind of special needs that older adults and people with disabilities have in this space. And I think there are a lot of opportunities when you look at what we can do to really help create housing options for older adults and people with disabilities. Like when we're looking at housing production, are we building housing that meets the needs of these populations? By 2040, California will have 624,000 new older adult renter households. That's an incredible number. Our older adult population will be about 40% of the renter population. And so what kinds of supports are we bringing into our affordable housing settings to enable these individuals to thrive once housed? And so I think, to get there, we need more housing, housing that's enriched with services for older adults and people with disabilities. We need to be a little inventive into how we house people, right? Because there aren't enough units, but there are enough bedrooms. So why isn't California investing more in home sharing, right? Where you can have an older adult live with another older adult, possibly help with caregiving. There are nonprofits out there that take
Audio.
Oh no.
Oh, here you are. You're back.
Okay. But yeah, so I think there are some innovative solutions out there, especially in the short term, to help address the housing issue.
Nina, can you round this out for us a little bit and sort of give us both the older adult perspective on how California is doing, and maybe help us move forward to make the connection between these different pieces, the setting, and just talk maybe a couple of minutes about that and where we are as far as like where those things are connected and where do we go forward from here.
Happy to. So first of all, I agree with everything everybody said. So that's my wrap up. I'm kidding. But everyone made some really cogent points. And I mean, when I'm looking at this and I'm thinking about the scorecard and again, how the pieces come together, the two bases really, and feel free to disagree, the availability of housing, affordable housing, that people can actually return to if they're institutionalized and or remain in their communities continues to be a challenge. And really the basis for our whole system of LTSS is family caregivers. And without these critical pieces, we are faced with situations that White raised up. For example, the higher percentage of individuals with low care needs not able to transition to the community from a nursing home. The other major issue that White also raised up really had to do with the, give me a second here, successful discharge to the community. And it just is so foundational to the issues that we're seeing. California, unfortunately, is not very affordable. We do hear from our members who are 50 plus who are struggling to make ends meet. They may have Social Security and a small pension. They can't find affordable housing unless they were fortunate enough to. They may own a home, but they sell it. Where are they going to go? Where are they going to go? And just with the cost of everything rising, and I know that the scorecard doesn't touch all the costs that we all face, but two big costs are in fact housing, as well as the cost of family caregiving, which average family caregiver spends $7,200 a month out of pocket with all, and that is just the average. So if you look at, for example, veteran family caregiver is 1.5 times that. So without these foundational pieces, we're really going to struggle ensuring that the people that want to be in their homes and communities can remain there. I also wanted to point out something else. So looking at the community integration piece, and especially housing and transportation, which I mentioned earlier, notice on the equity measure, which group is the most unduly impacted. It's white Californians. And I know Carolyn and I talked about this last week, but that could speak to the population in rural areas. Housing as well. I mean, even if you live in Bakersfield right now, you cannot afford to live in Bakersfield on, on just a basic wage. So to at least from our perspective, my perspective, it all kind of comes together, but without resolving some of those foundational pieces, and also speak to affordability and some of the work that's going on to get us to a program that will allow people to at least cover some costs of long-term sports and services, we're going to keep seeing these scores being pretty disappointing. So I hope, Hagar, if I've missed anything, ask me. I'm trying to round everything out and talk about foundations and where we go from here.
I appreciate it. I actually wanted to turn to Sawait for a minute. And Sawait, maybe you can talk a little bit more about what DRC has been working on recently as far as access to services and supports in the community, and really what your work is, or what you're looking to do in the next months or years to improve or fight for that community integration piece and the services equity piece.
Yeah, thank you, Hagar. This has been a really, great discussion so far, and thank you, Nina, for highlighting, those points. So, we at DRC, in regards to the affordability and livability, data that the LTSS scorecard highlights, we see an opportunity really for the state to, for example, look at the HCBA waiver and the wait list that exists, year in, year out. When you look at the cost of institutional care and you compare it to the cost of home and community-based care, it's night and day, right? For the HCBA waiver services, it's about $47,728 per year, while the average cost per year of a skilled nursing facility is $128,832. The difference is striking, right? And so we at DRC currently are, really working to improve the capacity of the HCBA waiver. We understand that DHCS is looking at increasing the limits to about 10,000 slots, but the data that we have shows that that's really, not going to do it for the need that we have. And I think that the LTSS, scorecard highlights a tremendous need. And so we're continuing to have, discussions with our state leaders about this. The HCBA waiver is just one example, right, of it's affordable for the state, but it also is a way for individuals, persons with disabilities, seniors, even children, right, to receive the care that they desperately need at home. And I think, sometimes, we can get stuck in trying to figure out like that new thing that we need to do, right? But oftentimes, isn't it so that there are existing programs that we might just need to take a closer look at and see how we can improve, right, efficiency and effectiveness. And this is just an example of that. So, for those who are here today and will be listening later, we would really, welcome you to be a part of the coalition to advance this cause.
Thanks. And I wanted to actually follow up on that because, you're talking about the work DRC is doing on improving capacity issues with our state waiver programs. And there's a question here in the chat about care deserts and the lack of infrastructure that some areas in the state are seeing. And I'm hoping maybe Carolyn and Donna and Megan, you can kind of touch on what you think about what investments the state should be making for infrastructure in your areas that will help make any sort of capacity increases in programs and actual reality, both from the provider perspective and also from the perspective of where people are getting their services. So I don't know, why don't we start with Carolyn?
Thank you, Hagar. Yeah, this is the big burrito topics, right? So when we look at our rural area, there's so much that is lacking. I know we've touched on the issue of racism and some of those issues going on. Megan, housing, we have tremendous support for house sharing in our region in the wake of the major firestorms. I personally live about 15 minutes from the city of Paradise. I used to live in Paradise. So we all know what happened there with the major fire, losing that entire community. There's no real recovery from that. But when we talk about the disparities, what we're really facing up here, I think there's two topics that really we cannot ignore in order to improve. One of them is blatant racism, and the other one is ageism. The racism in our northern region is so prolific that it actually made the national news recently. And that was at a Board of Supervisors meeting where there was open use of racial slurs. I received an email last week from a center consumer who was facing a local Board of Supervisors, and one of those supervisors told them that they were too old to be involved in political matters or really anything else, and that their time has passed and they needed to sit back, and they attacked them as an older person. This is unacceptable in any area. But when you're in a rural area and you're already part of a minority, the fears that you face just walking down the street are very real still. But there's hope, right? We have advocacy, we have huge collaboration going on to combat these things. We have issues to begin growing our own when it comes to facing medical care. For example, coming out of Shasta County, we have a group called the Shasta Health Rock Stars that are growing and nurturing young interest in medical professions and individuals that are willing to stay in this region and continue the fight for good quality health care. Butte County, working with Chico State University and UC Davis, are bringing tremendous innovations for interns in medical and behavioral health programs to study and come and do internships in this northern area. I believe there's hope. Tehama County, an initiative called Expect More Tehama, where they're focused on career and technical education. We have Butte County Home and Heart, which is a home sharing initiative. You know, Megan mentioned about rooms and houses. That's the largest available housing in our nation, is empty rooms and houses with people who want someone with help with IHSS or help with the lawn or taking care of the property. We can do this. And I think that's the attitude that we have. We can do this. We don't have to stay at these lower levels and sometimes dismal levels on these indexes. We join the AARP effort in this northern region because we want to stand strong and say we are part of what we call a livable community in the North. Scream louder and stomp harder in order to bring back into this region what our communities require post firestorms, post atmospheric river storms, because this is our home. We want this to be here for the next generations.
That's really great. Thank you, Carolyn. I really appreciate that perspective. And I'm wondering, Megan, maybe you can add on to what Carolyn is talking about. And maybe you could also walk us through for a minute about you'd mentioned home sharing. Are there barriers that you see or policy barriers or attitude barriers that are sort of preventing the state from really leveraging that resource? And what do you see the opportunities for both Carolyn's communities and the metropolitan communities for these policy changes?
Sure, thanks. And Carolyn, thank you for bringing up ageism because it's a huge issue, especially in housing. I can't tell you how many times I've heard, well, seniors can live anywhere, they can live in multifamily housing. It's like, okay, they can, but for how long? If there are not the support services in place to help them thrive and live independently, they're not going to remain independently housed very long. And same thing when we look at our unhoused population, we're seeing older adults being turned away from shelters if they have one or more if needs related to ADLs. Like if someone is suffering from incontinence, they're turned away from the shelter because the shelter staff is not prepared to handle that. And so there are just a lot of complications that arise here. And, when we look at housing, we are prioritizing a lot of housing that is like 4 bedrooms, 3 and 4 bedrooms for families. When many older adults can't afford even an affordable 3 or 4 bedroom or don't want an apartment that large. I think we really need to change our mindset as a society into like the types of housing that we're building and who we're building it for. And I hope that the state will start to see that this shift in demographics really necessitates the development of more affordable senior housing and housing that is built not only with the PSH model, permanent supportive housing, but with what we call service enrichment, which is really services that are geared toward people who are advancing in age or have a disability that is really tailored to their needs. And that is a very distinct product from permanent supportive housing. And we need both, right? We need housing options. And Hagar, Carolyn, you talked about home sharing. I think there is a lot of stigma around sharing a home. I mean, I think through our lifespan, maybe we often live with roommates when we're younger. And then, we get to a point in our life where we move out and we live on our own and maybe with our family. And then things happen through life. Your kids move out, maybe your spouse dies and you find yourself alone. And the thought of living with a complete stranger is very scary. And there are nonprofits that really work hard to ease that anxiety in people and to help make matches. Unfortunately, there's just not a lot of funding for these models. Different counties are funding some different models that are trying to incentivize home sharing. But I think until we can get over that stigma of sharing your home with someone that you don't know, and really kind of embrace the public benefit of it and the personal benefit too, as Carolyn mentioned, maybe you have someone that can help you take care of your home or help take care of you or your pets. And I think that's a big barrier right now, is just that stigma.
Also there's the question in the Q&A here about accessory dwelling units. Do you think that those are viable options, and can California do something to make them more accessible and doable for low-income and middle-income families?
Sure. I think ADUs are a good option. And I like to say housing is a puzzle, right? We have to have all the pieces of the puzzle so that everyone has options to live where they would like to live. We shouldn't be forcing all older adults into, an ADU or into an apartment if they want to live in their, single family home. We should create options, and ADUs are an option. ADUs are expensive to build, and so they need subsidies, right, to build them. And so there are a number of counties doing different things in relation to encouraging homeowners to build ADUs. I would love to see more counties that offer loans, like 0% loans to homeowners to build ADUs if in exchange the homeowner promises to like rent their unit to someone who to identify ADUs as the solution to older adult homelessness, because it's just a piece of the puzzle.
Thank you. Thanks for answering that. I wanted to also shift a little bit to IHSS and family caregiving, because we have a lot of questions about the in-home support program in California. And I want to maybe bring in Donna and Sawait on this conversation. Most of the IHSS providers in the state are family caregivers. So I'm wondering, Donna, if you can speak a little bit as to how what the issues are right now with IHSS family caregivers, and how we can leverage those family caregivers to address and provide care and care shortfalls in the state, and what we can do to invest in that workforce. And then maybe Sawait, you could talk about the non-family caregivers and what we should do to be investing in that workforce and making sure that they are, able to provide the care and also get the support that they need.
Yeah. In looking at the family caregiver who's an IHSS worker, one of the things that we probably could invest more in is helping them be able to take respite. Because if they're an IHSS worker and they're getting paid for a certain amount of hours, they still don't walk away when those hours are over. So a fair wage is still critical for those family members, many of whom are of cultural and ethnic communities, and they've left the workforce. We need to also find a way to help reintegrate them back into the workforce once they've left the IHSS position for their family member. And how can we, get credits for that time when they're an IHSS worker, so that they have some job training beyond that? Or do we help them stay in the field in some way so that we have more, ways for them to go? But they don't get enough relief as family caregivers. So they kind of are in this position where they're getting paid as a worker, but they're also not getting recognized as the family caregiver. And so their emotional and mental health needs may not be met as well. I think the other thing that we find for family caregivers is the way that, at least, I've noticed in the way that we divide up tasks, so that if somebody lives with a family caregiver, it actually, you lose hours and minutes, because they'll say, oh, well, you're going to cook anyway. Oh, well, you're going to go to the store. You're going to, you're going to be doing this, or you're going to be doing your laundry. And that may not be enough time, because they have their own, life. So we need to look how we evaluate the time for each of the tasks that are evaluated for IHSS. I think we could begin to do that. I think also for the family caregivers, many of them continue to need more recognition as for what they're doing, and more education. We may not be able to reach them and find different ways of helping them learn more about what they're doing at the rate that they want to learn. Many are already experts about their family member, but they may need other areas that you can support them with, so that they can continue to have something to do after their caregiving experiences and journey is over. So, and I talk a lot about informal, the unpaid family caregivers, but I'm going to let that go to someone else.
Actually, really glad you brought up the training issue, because I'm hoping maybe you can expand a little bit on the Cal Grows program and where you see sort of future changes or investments that should be made in that program, since it provides some of that training.
Yeah, Cal Grows has, there are two levels. They have some of the training is just for IHSS workers, and some is for the non-IHSS worker, home care workers. And those trainings, for, when I look over the menu of what's being offered, it's been really good, because part of it is, it does allow for some incentive so that people can get paid while they're trying to learn. Because particularly for an equity issue, we can't afford to learn and take time off from work. So part of that is you have to help the person be able not to have to choose between a bill and getting better at what they want to do for their family member. So if you say, well, I can't buy medicine if I have to take off work to go learn this, that's not a way to be equitable. So I think that's the education programs that are there. There also, I'm noticing within those education programs, there was a good emphasis on language, on being able to have it in multimedia ways so that you can learn, both visually, maybe in person, however people want to learn as adult learners, and using those principles. That was also part of what I saw in those programs. So I think that's good. Now, the problem, of course, is the funding's going to go away. And the journeys are usually 5 to 7 years. So taking a one-time snapshot, you actually need to continue to grow in your education because the person changes over time. So what you might have learned 2 years ago is not going to apply for 4 years from now. So we have to continue to make these educational investments and be able to see a way for, while some of them are going to be memorialized by video, that's not always going to be the same as helping people know that those programs are there. And so we have to continue to have some investment for dissemination at a minimum.
Great. And I see in the chat here that Sarah Steenhausen clarified. So CalGrows is for non-IHSS family caregivers, and then we have also the career pathways program for the IHSS caregivers.
Yeah.
And so White, maybe you can talk a little bit about that. I think it's 30 or 40% of caregivers that are non-family caregivers through IHSS, and what investments you think the state should be making there, especially in light of the number of unused hours that are allocated, but people can't use them because they can't find caregivers. What do you have to say about that, and where should we be making those investments to improve?
Yeah, for sure, Hagar. Thank you. Well, I would just wanted to share that DRC this past legislative session worked on making improvements to the parent-provider rules within IHSS. It's, these complex rules, but essentially what we were finding was that there were children mostly, and families we were representing with minor children who were being denied IHSS services because one or both parents were undocumented. But because of the parent-provider rules, they were also prohibited from hiring a non-parent provider. And so we worked with the administration, and our legislative leaders to address this, right? And so there were changes made to the parent-provider rules that actually now allow families who are in this predicament to hire non-parent providers. And so, I think just in general, right, we do see that there is a shortage of providers. There's a growing need for care, for home and community-based care for IHSS services. We're also seeing that there's a growing need of people who need these services who don't qualify, who are not income eligible for IHSS. So we're, continuing to have to hear from folks, different groups that are interested in, addressing the needs of, I guess some would call, the missing middle. And so there's a need, right? I think that's the point here. There's a growing need. I think there's a lot, that we need to do. I don't have the magic answer, but I think that, there are certain counties throughout the state that leverage, local funding, local city county funding to find creative ways to meet the need, right? I think that we need to start bringing, we need to all come to the table and start exploring creative ways that we can meet the need, really, because the need continues to grow, and we can continue making fixes to the way that IHSS currently works and operates just as I shared we did with the parent provider role. But I think there really is a need to find creative ways to meet the growing need that we're seeing, Hagar.
Thank you for summarizing that. That was great. And I think we're out of time, actually, right on time. So thank you so much for everyone's input and participation. And I'll turn it back to Maria.
Well, thank you so much, everybody, for making yourselves available, being part of this panel. We're actually going to take a short break. I know this is a longer session, and so this is an opportunity to get up and refresh coffees and use the restroom. And we'll be back in about 10 minutes or so. We'll see you at about 10:40. Thanks, everybody. I moved around on me a little bit. Hi, everybody. Just calling us back to order. It's 10:40, so we'll pick up where we left off. And I am actually going to introduce or reintroduce Narda, Vice President of Policy at the SCAN Foundation. She will be moderating our next panel discussion. So Narda, I hope you're ready to come on stage.
I'm here. Good afternoon, everyone. I'm very excited to be. Oh, are we good to go?
Oh, we're good to go whenever you're ready.
Great. Very excited to be moderating this panel with reflections from folks from the state who can really, I think, dig into some of the questions and robust conversation that have already been had later today, but really providing that state lens and state perspective. So really excited to have with us Susan Damaris, Director of CDA, California Department of Aging, Elizabeth Fuller, Chief Consultant for the Assembly Committee on Aging and Long-Term Care, Marco Mitchik, Undersecretary, California Health and Human Services Agency, and Shiki Wikrema, Deputy Secretary of Homelessness, Business Consumer Services, and the Housing Agency. Thank you all so much for being with us today. So I'm not sure if you all had an opportunity to listen into some of the conversation that's already been had today, but really robust conversation and engagement, recognizing, challenges of LTSS affordability, the intersection of all of that with housing and housing affordability, and really understanding that this is, there is no sort of one size fits all answer to all of this. But think that from where you all sit, we can really get a better understanding of, what your priorities are, how you all are thinking about some of these issues and questions, and how stakeholders and the advocacy community can help to support some of your priorities and your programming going forward. I think I'll start with just, that question about affordability of LTSS and trying to get from your perspective, your all's perspective, what do you think is needed to ensure Californians have access to affordable LTSS options? Particularly, we heard increasingly this is an issue for those that don't qualify for Medicaid and are in that sort of missing middle population and it's unable to obtain some of those services.
I'm so happy to start. Thank you for this convening and thanks for starting with, the hottest topic there is. So, I think first of all, we can be really proud in California, and it's reflected a bit in the scorecard, pushing the envelope with Medicaid to ensure that as many people as possible can qualify for Medi-Cal in our state, can access the home and community-based services that are available through Medi-Cal in our state, whether it's the asset test or expanding Medicaid coverage to undocumented, more than 300, pushing on 400,000 individuals over the age of 50 now have full scope Medi-Cal that didn't have it just a few years ago. So we can be very proud of that. And also, with CalAIM, what we're doing with enhanced care management and community supports and rental assistance. So for the individuals who are Medi-Cal beneficiaries, that they do have access, I think, in our state to more home and community-based services than most other states. That does leave the missing middle, as you say, and I'm so glad that Liz Fuller's here joining us. So the work of advocates, stakeholders, the legislature, and of course this administration to really start exploring some pathways for LTSS financing that can, help relieve the burdens of the missing middle or the forgotten middle. And I know Marco's done a lot of work in this space. If Marco would like to add to that.
Yeah, thanks, Susan. I mean, I think I echo everything that you ultimately, I think, raised. I think the thing that is important to point out here is that the acuity of the issue with regards to that forgotten middle, so those individuals who might not be eligible for Medicaid, but they don't have the resources to be able to support themselves, is particularly acute and something we're spending a lot of time thinking about. And we're getting at this in multiple prongs. I think one, how do we further look at ways in which we leverage both our HCBS investments? And so we really looked at kind of pushing the envelope even with our HCBS investments that we came out with over the course of the last couple of years to really begin to think about how we build up the continuum there. I think the second to Susan's point really is how do we leverage Medicaid as far and as wide as we possibly can so that we bring down into California every possible federal dollar to cover as many people as we possibly can is an important thing. And then the third piece, I think, though, you know, as we think about all of the financing components, I think we also have to recognize kind of the caregiving aspect of all of this. And for us, I think it's a combination of the fact that the workforce isn't sufficient, right? There's not enough people to take care of the individuals who need care in a home and community-based like setting. And so what do we do to do that? And then we also recognize many of us are caregivers ourselves, and we're, you know, are unpaid caregivers. And I think the reality of the burden of that, although it shouldn't be a burden, it at times is a burden. And I think that it also puts an enormous amount of cost pressure, particularly on women and women of color in particular. And so how do we grapple with those pieces as we look to proceed is going to be really important. And in my generation, we are kind of sandwiched because I've got young children who are in daycare. So we're looking at the care economy from the perspective of that aspect. And then I've got elderly parents who are aging and are in need of care as well. So we are in this spot where we're having to look at this from both ends, and it makes it really difficult to navigate. So just to add to kind of the complexities of the things that Susan alluded to.
Thank you very much appreciate that. And I think it certainly resonates with a lot of the conversation that we've already had this morning. And as we've talked about, you know, the LTSS access and affordability is one piece of the issue, but equally important and increasingly, you know, recognized is the importance of housing, and particularly in a state like California, where that, you know, housing affordability can really be out of reach for many. And existing programs and supports that serve individuals who are housing insecure aren't as well sort of acquainted with the aging population. And so I'm wondering if we can turn over to BCSH to talk a little bit about how you're thinking about the housing piece of this puzzle.
Thank you, Nada. Dakshika from BCSH. So one of the things, and this came out in the previous panel, and Carolyn actually mentioned that it's a daunting challenge, Nada, because some of these are structural pieces that have been building for decades. So for example, the rent has increased over the last 10 years by 40%, but people's incomes have only increased 8%. So many people are being priced out, and you know that you came up from not only folks receiving care, the caregivers have nowhere to live if they don't live in the home, right? And then the other issue is we think a lot about homeowners, but many cities are actually majority renters. Just because you have a spare room, you can't bring somebody else in because you would be violating the lease. So you have issues when you're a renter versus you're a homeowner, even to bring somebody in or even to share costs. So one of the things we are doing at BCSH is we are looking at how we can do more cross-sector collaboration and kind of intersectional work across the multiple sectors. Because, for example, you heard last time that the disparities issue. So about 5-6 years ago, I was on a panel looking at women homelessness, but no surprise, Black women and elderly Black women more likely to be kind of impacted by all the economic pressures. So what we are doing at BCSH is, and I'm going to talk about 3 levels of collaboration we're working at the local level, at the state level, and with our federal partners, because we want to look at how to tell the story and unearth root causes. So everybody's working together. It's going to take small and large actions, but collectively to really figure out how we can come up with solutions that's decades in the making. So at the local level, BCSH has a department called the California Interagency Council on Homelessness. And I'll say more about that in a second, but they do provide formula-based and competitive grants to locals. And what we have done is to try to forge collaboration across sectors and interjurisdictional kind of collaboration we have required, because every county gets this money, that we are going to measure how they collaborate across sectors. So is the homeless entity collaborating with the managed care plans? And we want to see evidence of all of that in their application. The second thing we're doing is really asking them to track how they are serving people, how many people are being served, demographics, how many people are exiting from homelessness to housing, how long are people staying homeless, and then we also have equity and racial disparity measures that they have to track along with us and submit back to us. So that's one way at the local level with our grant making that we're really trying to forge cross-sector collaboration and evidence-based practices, including, speaking of the housing NADA, we are going to be really making sure that they are committing and implementing their goals around regional housing needs. So every jurisdiction in the California state has to meet regional housing goals, especially for people who are considered extremely low income or very low income. So just to give you a sense, if you're extremely low income in Sacramento, you're making no more than $22,000 a year. So that's how deep we're trying to target kind of the housing. So that's local level. At the state level, and Marco knows this because my boss, the secretary of BCSH, and his boss, the secretary of CalHHS, they co-chair a state council with the California Interagency Council on Homelessness Supports. They convened the state council made of 4 agencies, 14 departments, including the Department of Aging. So Susan DeMorris is on this council. And again, this is really trying to break down silos and create more cross-sector collaboration. There's a state action plan with joint activities across these agencies and departments over 5 action areas, including building more housing and prevention as well, because as you pointed out, Nada, we really want to make sure people don't end up being homeless before we kind of intervene. We want to prevent, and this is where the other systems like the healthcare system, the employment system, the education system, the homeless safety net system really need to step in before the homeless system kind of has to catch folks who've been failed by these multiple systems. So this state action plan, we do it every year, and in the coming year, there will be an updated version. And I want to give a shout out to CDA because they really did not a good job of connecting the master plan on aging to this action plan to prevent and end homelessness. So that's the state piece a little bit. And then finally, with federal partners, we have just California joined a federal pilot effort called All Inside. We are one of 6 jurisdictions across the nation. It's a 2-year effort to really unearth federal barriers that prevent people from accessing housing and services. And we took the position of taking a person-centered approach. So we are focusing on 3 populations, including older adults. And how we define older adults is 50 plus, given Professor Kushell's research that people experiencing homelessness when they're 50, they present as people 10 to 15 years older. And the last thing I'll say is, again, to go back to kind of the disparities in the homeless system, what we find is even though Black Californians are only 6% of the state population, they represent 26% of the people being served by the housing and homelessness system. So very stark disparities, that's why we are intentionally tracking those things. So that's how NADA, we are really trying to think about a kind of whole of government approach, but also at the local and federal level, having partnerships so people are really working together to tackle this.
Thank you. It sounds like a very robust plan that you have in place, and I'm glad that they're leading those efforts. Speaking of sort of the cross collaborative nature of a lot of this work and the need for that collaboration, obviously, appreciate you sharing how the different agencies are coming to work together. Curious from your all's perspective, how the stakeholder community can support those efforts, help to support some of that cross collaboration, because I think we heard from folks today on this call that are participating a real desire to be able to help support in any way that they can. So if you have tips for how folks can be engaged and help to advance your efforts, that would be incredibly welcome. And I think, Liz, hearing from you as well, and just in terms of, given the cross-jurisdictional nature of a lot of these policies, how stakeholders and advocates can support those efforts at the legislature as well.
Did you want me to start, Nada? I can.
Sure.
Okay. So at the state level, I mentioned the state action plan, and there will be lots of listening sessions and input sessions. And in fact, Susan and the others will be asked to go to their affinity groups and their kind of networks to really get feedback around the different joint actions that they would like the state to take in the next iteration of the action plan. So really encourage everybody, stakeholders that are interested in things related to the aging population or the master plan on aging, to think about how on housing insecurity or interventions for people who are homeless, they can really provide input to us through CDA or other kind of agencies in the council. I will also say the council's meetings are public. They are once a quarter, and November 30th is the next council meeting. So people are welcome to join and provide public comment. In fact, this is not public yet, but Susan will be providing a quick update on the master plan on aging. And at the local level, the last thing I'll say is I would encourage people to find out more about the regional housing needs, goals, and encourage people to go to meetings at the local level, say yes to housing of all sorts. Don't be a NIMBY, be a YIMBY. So I would really encourage people to be active at the local level to encourage housing.
Liz, did you want to? Yep, there you go.
Yeah, I'm going to jump in. First, I want to thank, a lot has been said about collaboration. And I think that everybody on this call, I'm so lucky to work with the Department of Aging. They are the dream department in the state. And Marco is amazing and always brings forward, I think, which is a unique perspective of being a father as well as being a caregiver. And so I really appreciate you bringing that forward, because it is something that often we as women, it is a part of the definition of who we are. And I think that is why it so often is seen as women's work. And it is something that is human work. And it is part of who all of us strive to be. I also want to thank SCAN Foundation, who have been instrumental in me learning everything that I needed to know. And also to AARP. To thank you to the people who work with AARP, as well as the volunteers who are often there doing the work. So shout out to collaboration, because I think it's important. And I think that I spoke yesterday to the SCAN Foundation on a couple of things that, while this isn't the question that was directed towards me, I'm going to just share a little bit. One, I think naturally the master plan for aging gave us a collaborative nature. Everyone came together, everyone discussed some issues. And then we had, a very evident reason to pivot and to redirect some of our hopes and desires to make a more immediate change. But I'm grateful for it being a byproduct of what the master plan for aging set forward. Talk a little bit about what I see happening on a state level with the budget. It's very confusing to be outside of a pandemic and have revenue continue to be pushed back. I'm not understanding necessarily how we were able to put forward a budget when we didn't know how much money we had, but yet we've done it. Not to say that we as a state aren't familiar with spending a little more than maybe we have. But I think that when people keep asking the question of where are we, that's the million, actually, what is it, $400 billion question, is where are we? And I don't know. But I can tell you that funding is always an issue in any of the human service spaces. But it's particularly difficult when in the aging space, so much depends on federal funding, particularly in our health and wellness space, right? So much of that money comes from the federal government. And so while we have mandates on what we are required to do in some programs, we don't always have the funding. I do think that we have a very unique space that we have had 30 years of phenomenal programming that has gone unfunded or underfunded for years. And so sometimes we don't have to fight to say this program should be in place, but we need to collaboratively fight and say this needs to be funded. Our needs are only going to grow. And so when we have the parameters of programs already being in place, we need to fund. And that is where I would give my advice for advocates out there on how to work towards that funding. And I think a lot of advocates work in this fall time on building how they want to move forward in the coming legislative year. Well, we haven't, I think we are now at tax day. 2023 is now, and that's odd. So how much money should you be planning to ask for? We still don't know. But what I do think we need to start doing moving forward is not just saying to be flexible, because we always need to be flexible, but to really build your asks kind of with a plan A through F. And that allows that as we're very, very quickly moving through the legislative process, moving through a budget process, that we're able to say, wait, we're still meeting where we want to go, and we're going to now move to plan C without having to stop, reconvene your group, find out if everyone is on board, and then move forward. Because at that point, you've missed it. You've missed your mark. So I think that that has been undone in years past, is really having multiple approaches toward a goal. And I don't mean just in funding numbers, I mean in how you hope to get there. I think that there are lots of different ways that we can flowchart a budget ask. And I also think even though if we are in a tight year, budget asks are still important. People still have needs. And oftentimes members, I have heard, will say, I can't pick up a budget ask this year because I still promised 2 years ago to this group that I would make their budget priority my priority. And so I think in the aging space, we're so polite. We are so polite and have constantly waited in line and let someone else shine because we think we're doing okay. And it's time to really stand shoulder to shoulder with everyone and say, hey, I realize it's all the same pot of money, but we all have needs. And often what I think is missed is we are a state of 58 counties. But oftentimes a group of counties in the north has more in common, say with South Dakota, as far as what they have access to, what their geographic deserts look like, what access to services look like. The chair of aging is from Kern County, and I was just there last week. It is a county the size of the state of New Jersey. That goes forgotten in a lot of conversations that we legislate statewide, but how that really impacts all of these different counties is really insufficient. And so I am a huge fan of pilot projects that show a demographic and where things may work better than others. I'm a fan of within pilot projects of every year or mid-project reporting back. Because I think that when we show something can work in a certain area, it doesn't mean it'll work statewide, but it may mean that we can start legislating things based on geography and population and demographics, and not just based on we are one state. Zipping it, go.
Really appreciate that thoughtful response, Liz. Thank you.
And Narda, I just wanted to build off of that to just remind your listeners that we do have 6 standing stakeholder advisory committees that are tied directly to the master plan for aging. And I want to thank all of the committee members and stakeholders and public members who work between meetings. housing is one of our work groups. I don't know if Marty Emoto is on, or Patty Prunehuber, certainly Megan Rose. We've plucked the housing experts from our disability, aging, and community living advisory committee. We talk about transportation there. Debbie Toth gets, she's the ringleader for, but what's so interesting with the LTSS scorecard, as well as the master plan for aging, this, the notion of cross-sector, multi-sector, cross-agency, multi-agency, whatever stakeholder committee it is, these same issues surface. If we're talking about elder and disability justice, we talk about housing, we talk about behavioral health in that setting. It's not limited. When we talk about community living, we talk about housing. On the Alzheimer's Advisory Committee, the issues of housing and homelessness and behavioral health surface in that setting. So, the good news is we're cross-pollinating. And then, of course, with the Interagency Council on Homelessness, where we're focused squarely on housing, again, these issues surface, the lack of caregivers, affordability. So we do see a lot of overlap and synergy in the best possible way, not duplication, but synergy. And then I'll just say that, we're already starting to look ahead to our next round of Master Plan for Aging initiatives for the 25 through 27 year. And this scorecard is helping to inform that work. And we will have another day of action, October 8th of 2024, to bring all stakeholders together from across the state to, help us prioritize our initiatives for the Master Plan for Aging.
Thank you so much, Susan. And you just touched on this, and Marco touched on it earlier as well, and Liz too, about really the importance of caregiving, as well as the direct care workforce, in terms of that being a critical component of a high performing LTSS system, as evidenced by things like the scorecard. And it's something that our attendees, several questions have come up throughout the discussion today around, how we address some of the workforce challenges, both in terms of, divisions in wages between IHSS workers and those that are in residential communities, family caregiving, and nurse delegation. Curious if maybe we could start with Marco, with you, about some of the things that you're thinking about in terms of helping to bolster the workforce.
Well, I will just say, I think this is a really hard topic and we don't have all the answers, right? I think we need to acknowledge that first and foremost. And I think it is important for all of us to really come together and think about all of the different solutions that can be leveraged in the space to both support the paid and the unpaid caregiver. And I think that the reality is that we sometimes think that this is just an older person thing, and it's not. And I think that no matter where you are in your lifespan, you're going to be in need of caregiving at some point in that life stage. Either you yourself will need to be needing that care, or you might be providing that care. And I think it's important to look at both of those things. The way I've been thinking about it, and this isn't perfect, but I really have been thinking about kind of what are the two kind of key drivers of this problem altogether. And I think there's two that really kind of resonate with me. And I'm not saying that this is perfect, but it's at least how we're beginning to think about ways in which we shape our thinking and our work. One is really a dwindling in the labor market of caregivers, right? Who are both unpaid, underpaid, or paid, right? It doesn't matter where you fit in that bucket. And this disproportionately falls on women and women of color, as we've alluded to before. And I think that there are ramifications to that, because things like leaving the workforce to care for somebody means that your Social Security, for example, down the road is going to be less than what you would have if you were in the workforce for a longer period of time. And so people are burned out, they are exhausted. And I think that as that market dwindles, that labor market dwindles, we at the same time have this wave of individuals, which is a blessing, of people who are actually living longer. And so I think we are stuck with this conundrum where on one end, we are seeing less people in that type of profession. And on the other hand, we're seeing this ginormous demand for people. And so there's a market failure there in itself that I think we're beginning to unpack and think about what that ultimately looks like. And of course, we can do things to support the paid and unpaid workforce. We can think about new models where we look to lift up, we can increase the wages of those individuals. All those things are solutions in the toolbox to help us think about it. And we've got to get even more creative in thinking about what that looks like. The second piece to me is really looking at kind of the economic misalignment when it comes to LTSS and caregiving in particular. And what I mean by that, really, it's about how do we think about high quality caregiving that is affordable. Today, it's really unaffordable for a lot of people. And it becomes an equity issue, as many of the panelists have alluded to earlier. And so really thinking about how do we mix and match resources to be able to realign that economic incentive so that it not only is more accessible to people, but is more affordable to more people. And so those two kind of drivers, I think about a lot, and our team thinks about a lot as we begin to work with Liz and the legislature and others around what are the solutions that we can be putting together to really drive at a more holistic long-term services support system. And I think to the comments that were made earlier, I think this is both what can we do as a state, what can the federal government be doing more and differently? How do we leverage Medicare, for example, in a different and more robust way? And we should be thinking about pushing our federal partners in that. And then I think it's also about what is the private sector doing? What types of benefits are we providing to employees to be able to take advantage of? This isn't just a government problem, this is a whole of society problem. And the way we took at this with the master plan for aging is to say, we're not going to solve these problems by ourselves. We're going to solve them collectively across sectors. To Dakshika's point earlier about our housing work and our homelessness work, this isn't just a one sector problem. This is a multi-sector problem. And I think that's true in this space as well.
Thank you. Really appreciate that response. And again, it's a topic that is near and dear to all of us on this call. I do want to allow time for attendee Q&A, but before we move on to the broader conversation, just one last question. I think, to leave us with some hope, we do recognize that, the state has been doing quite a bit of work in the space. We have things forthcoming like the long-term care task force recommendations on long-term care financing, the HCBS gap analysis that CDA has been leading. And so I'm curious if you can just touch on, what you see as sort of the immediate sort of vision for long-term services and supports, given all the activity and all the analysis that the state is doing right now to address some of these challenges.
Well, I'll start and I'll turn it over to Susan for a minute. I think we have a lot more work to do to connect the dots between the disparate systems and figure out ways in which we leverage them even more. And then I think we have to think really creatively. We don't know what type of a budget situation we're going to be in, but that really shouldn't really prevent us from thinking creatively about ways in which we further leverage the systems that we have. And what I mean by that is, Susan alluded to kind of our CalAIM efforts and ECM, enhanced care management and community supports. We ought to be thinking about how do community-based organizations, area agencies on aging, others become ECM and community services support providers, because those things can be helpful in moving the needle. The challenge there is it's daunting to think about being a provider when you don't know how to navigate the Medicaid system. You don't know how to bill, you don't know how to look at the data. And we got to do a better job of thinking about how do we get community-based organizations who are closer to the ground to be able to leverage those supports. But those are benefits that are available to people that people are not taking advantage of, partly because it's daunting to think about how you ultimately navigate that space. So it's on us, the state, to think about better ways in which we connect the dots and also begin to think about ways in which we go outside of the traditional norms of where Medicaid is to be able to think about how we get closer to people in the community to provide those supports. But I'll pass it off to Susan to add to that, or correct.
No, that's exactly it. And just, I feel very hopeful. And, one of the reasons is ours is a 10-year blueprint for our state. We're just wrapping up year 3. So, all along the intent was this wouldn't happen overnight. And Several of us on this call were part of a collaborative last week. The Center for Healthcare Strategies brought together a dozen states that came to Sacramento to learn about our master plan for aging, and our flock is growing. The more this takes root as a national movement, some talk at the federal level applies more pressure, and it's great that we are leading the charge and leading the way, and it's not a coincidence. I mean, the demographics are fueling this, and national scorecards like this that put every state, on the map and get the attention of the National Governors Association and the National, Council of State Legislators, that more and more people are talking about this, and the key themes are rising to the top. The themes that were identified in our LTSS subcommittee, navigation, access, workforce, affordability, those themes, every state is grappling with the same issues. So, that's what I see as exciting, is we have the demographics behind us, and we're starting to do the planning. And so those two combined make me really excited about what's ahead in California, for sure.
I will just add one more thing, and then I will be quiet. I think it's really important for people to recognize that a thriving LTSS system more broadly, and a thriving, for lack of a better term, care economy equals a thriving economy in California overall. If we do not get a handle on the first component of it, we will not have a strong, because as I alluded to my own experience, my wife and I have to think about who is on deck to do what when our kiddo is sick or where a parent is sick. And that has an implication on me as an employee of the economy and the outputs that I provide as an employee of the state. And so that is not unique to government employees, that is unique to all sector employees. And so if we think about this, we've got to think about this equation more holistically. This isn't just an issue of when you get older. This is an issue about the underlying aspects of our economy. And if we are serious about those pieces, that's why we're working on a master plan for aging and all these pieces, because fundamentally this lifts up our entire economy as a whole.
Yeah, thank you, Marco. And I think that sort of reinforces the point that you made at the start of this panel, which was that this is an issue that touches everybody, and it really is, there is a need to change the narrative that this affects just, a small subset of the population, that at every point someone is either a caregiver or is a recipient of caregiving. And in that same way, we are all participants in the economy, and it has an impact on all of our lives. So I really appreciate that. I do want to move over now to provide an opportunity for the general Q&A. We do have a couple of questions in the chat, and we'll remind folks that if you do have a question, please feel free to go ahead and type that in the Q&A box, and we'll try to get to those that we can. We have a question from Juan Guerrero, and I think this is really a nice segue into this next part of the conversation. One of the things that we haven't touched on as in detail yet is really around the sort of racial and ethnic disparities of this issue. And, that one being for the first time ever, a component of the LTSS scorecard, and something that the scorecard is starting to capture, but also is such an integral piece of the California Master Plan on Aging and so many of the other initiatives happening all across the state. So I'm wondering if you could share a little bit. I think this could really go to anyone on the panel who would like to respond, but how are you all thinking about sort of the racial and ethnic disparity component of this as you are developing your policies, programs, et cetera?
Susan, you want to start, and then I can piggyback
Sure.
with a broader
Sure.
agency view. I mean, you can start with the aging and master plan, but I'm happy to also lean into the broader agency stuff.
You got it. And thank you for that question. I think it's something we think of every hour of every day in our planning and design. And again, I would just really like to commend our stakeholders, starting with the Equity Advisory Group of the Master Plan for Aging, that stuck with it and developed an equity lens for the original goals, strategies, and initiatives. And then that group stayed together and added new perspectives. So it's a really robust, active group now that we're working in consultation on an equity framework for the master plan for aging with our stakeholders. And I think as our data matures, really the goals of being person-centered, data-driven, and equity-focused, they're inextricably linked, if that's how you say that word. And so the more data we have really to drive investments, drive programming, and certainly part of our home and community-based services gap analysis. Marco, turn it over to you.
Yeah, I mean, I think this is not only important in this space, but it's important in everything that we do at the Health and Human Services Agency. And one thing that I think is at the core of this is the governor's directive and the secretary's directive to really embed equity in all that we do. And even Dakshika's comments earlier, I mean, I think that's the way BCSH is thinking about this too, from a perspective of the ICH work. And fundamentally what this means really is that equity is not an afterthought, but it is at the forefront of every action we take and every policy we develop and every program we look to implement. And I think what we mean by equity really is the notion that there are people who disproportionately for many, many years over time have been marginalized by our systems. And there is intrinsic racism in some of those systems over time. And so it is our duty and obligation to begin to think about how we lift those individuals higher so they are on an equal playing field compared to those who have benefited from many of these systems over time. And I think what happens too often, and this happens amongst our own workforce, is that we really mistake equality and equity as the same thing. And equality for me really is about giving everybody an equal share, and equity is giving some who've been marginalized and impacted at a higher rate a greater share or more support to be able to navigate that, because the system and the processes over time have built up this negative consequence in terms of people's ability to actually succeed. And this is more true in the LTSS space more than any place, if you think about it, because people have had the assets that they could build up to be able to get the supports and services once they are older. Many people of color might not be in that same instance. And so this isn't unique, and we should not just think about this in this space. We're thinking about this in everything we do, whether it's childcare or our work around expanding access to Medicaid. This is all about equity as an anchor in terms of our work and our thinking.
Yeah, I appreciate that response, and also just want to acknowledge Dakshika's earlier response about embedding the requirements around some of what's happening at the local level in terms of tracking the racial and ethnic disparity measures, et cetera. So I really appreciate the work that all of you all are doing to really make sure that this is embedded in everything that you all do. I think we have time for one more question. And one of the questions that was posed in the chat is to learn a little bit more about how you all are thinking about the evaluation component of some of the initiatives that you all have embarked on, and how that can support further expansion or scaling. But if you could share a little bit about some of the evaluation sort of programs that you have in play.
Dakshika, do you want to talk about some of your guys' work, and then certainly we can fill in some of the things that we're working on too?
Sure. So we, as I mentioned, have formula-based grants and competitive grants. So the evaluations built in to all of those. We also have kind of vendors that we work with, because I didn't mention when the locals collect the data for the very first time now, California aggregates all that data. And we have a statewide picture. So if you go to the BCSH website, there's a web page called HDIS, which is constantly being updated with kind of the local data aggregation. So we have evaluations based on that, and we work with universities. We did a 3-year analysis of that data collection work. But I do think some of it is, I think somebody said this, maybe Elizabeth, we know what works. Some of the kind of pinch point is scaling to meet the need. when an evaluation says this is what works and this is what works less well. So I will just say that some of the challenge is when you know what works, but you're trying to kind of think through how you scale to meet the immense need in California. I'll end with this one thing before passing it on to Marco. For example, thanks to the governor and the legislature, we have tripled production of affordable housing for very low income and extremely low income households over the last 4 years, but that still meets only 20% of the demand. So
I think the other thing about evaluation, the traditional sense of evaluation, is you finish a program, you then look at the data, then you wait 5 years for it to be published in the Health Affairs or in the New England Journal of Medicine. And by that point, Liz is already like working on all the bill ideas, right? And I think, to me, we've got to think about evaluation in more of a rapid cycle. And partly what I love about both what Dakshika is doing and then what Susan's doing at Department of Aging is that we're incorporating data elements in our dashboard on Master Plan for Aging now, so that we can in real time say these things are working and these things are not working, and not be afraid to make a pivot and say, let's be nimble and understand that, you know, maybe this isn't working as we thought it would. Too often in Sacramento, we theorize about these policy ideas, but in practice, they just don't implement the same way. And that's okay, right? Like, we've got to be able to learn. And we've got so many unique jurisdictions, to Liz's point earlier, that it might look different in up north than it does down south. And it is okay for us to be, bottom line, I think we need to think about evaluation in a very different way than we've traditionally done. Because if we think about evaluation in a traditional way, we will not influence the policy process, both in the executive branch and in the legislative branch. And I'd love Liz's perspective on this as well. But we've really got to figure out, how do we reevaluate in real time, use that data in real time to say, look, Liz, we are seeing these issues here. Could you work with us on a regulatory or on a statutory scheme that addresses some of those pieces? That, I think, is more useful than waiting 5 years till the program is done and the money is gone for us to go back to Liz and say, Liz, guess what? This didn't work the way we thought it did. Maybe we need to make these statutory changes.
So this is church to me, because everybody's just preaching and I love everything that everyone is saying. Just to piggyback on what was said before, that in the public space now, in the assembly particular, it is our charge to see how every policy put forward impacts disparate communities. It's a part of every analysis that I write. I mean, most often I say this is going to impact aging in a positive way, because for obvious reasons it will, but then you kind of bring out one thing that I said years ago when I worked in the Women's Caucus is we live our culture every single day. Gender issues aren't always forefront, but my culture and who I am intrinsically in my home, I live every day. I live it with my family, I live it with my children, and that's unique. And that can be geographically who we are as a culture. It can be how we were brought up. It can be our language. It can be so many different things. But I think if we are not addressing how people age culturally, we're really, really missing something. I'll tease Marco a little bit and say we never really use the word scheme in public policy because it's kind of frowned upon. But whenever you're bringing something to me, again, it's why I'm such a fan of a pilot, to say, let's try this. Let's try it on a smaller scale, and let's try it in a few different points. When we try pilots, you would be astonished how long it may take for me to pick 5 counties, right? How do I pick those 5 counties? It's a wedding seating chart. It is, have I picked coastal? Have I picked north? Have I picked south? Am I big, small, little? Am I urban? Am I rural? You really want to find a way to pick a few of those and see, would I get a good cross section of how this would impact the state? And sometimes I'm anticipating we may get back, this may only work in urban settings, or this may only really work in the rural settings. One thing that I've done recently, and I thought was the biggest eye-opener I had in aging programs, was being a part of grant reading for grants on a state level, and understanding that what a program who is asking for a chunk of change in the greater LA area has, and how they plan to do it, and the supports that already are in place, and how they can easily get that money out and what they can do with it looks very, very different than Humboldt County. And it is a beautiful thing to see how in some areas they have all the supports they need from state government, from county government, all of it. It's ready to go. We could give them the money right now and they could get it all out. How honest some may be about we're going to partner with, we'll partner as we always have with Meals on Wheels, with the veterans, with Rotary, with our board of supervisors, and how we are going to take everyone collectively and make this work. It is staggering how much work goes in to asking for those dollars, when it is embarrassing sometimes when we're talking about state funding, how we become a little immune to what an actual dollar spends. So I think that everybody that's probably listening in, and everybody that has spoken today, we're all chugging along and trying on the workforce issue. I think that it needs to become a normal part of being a worker. I'm 30 years into my full-time working life, and I have been a caregiver at multiple times, but never a full constant. I have never gone to my employer and said, I no longer want to work full-time because I've decided for the rest of my life, I am going to have these caregiving needs. They have ebbed and flowed at different times, but they have been a part of who I am. And I think that we need, as employees, to no longer worry about coming forward and saying, you know, a part of who I am is a caregiver, and I have these short-term needs and accommodations. What we've learned from the pandemic is accommodations. We've done it. We know that we can still be a worker. And, you know, I look forward to seeing these future scorecards and seeing the progress that we can make, and how we are also committed to this work.
Thank you so much. And I thank all of our state panelists for their time, their perspective, and their engagement. I think it's been a really rich conversation. And again, yeah, just really appreciate your willingness to participate and be here with us today. So I'll turn it over back to Maria.
Well, thank you so much, Narda. And I'm going to manage cameras here in the background a little bit. And I am so delighted to introduce our closing speaker today, Ms. Kim McCoy-Wade, Senior Advisor on Aging, Disability, and Alzheimer's for the Office of Governor Gavin Newsom. Kim?
Hi, Marina. Thanks so much. I will be very brief since we're at time, but what an incredible 2 hours we just sat through. A couple quick points. First, I can't thank AARP enough for the scorecard. When the Master Plan for Aging Executive Order was issued way back in 2019, this scorecard as a baseline really grounded us on the reality check of where we were and where we needed to go. Again, when it came out in 2020, and at that point, Blanca Castro briefed us on where we were and where we need to go. And to see it here with, again, so much progress, the updated indicators, Master Plan for Aging in there, just so thankful to AARP, and then really to all the stakeholders and our government partners who, just like the Master Plan itself, are committed to have this not just be a scorecard, but that it is an action driver. So I don't have to tell you all, the governor would not be satisfied with being second. Second is maybe good enough, but not for the governor. We don't want to be second in California in healthcare, in mental health care, in child care, or in elder and disability care. And so that commitment to care and to caregiving and care work is fundamental to our administration. And we have 3 more years to get to that first tier. And of course, the master plan has 7 more years, but time is urgent. It's urgent for families. And so I can say, my last thing I want to say is I am very clear about 2 things. And I think 3 things are up to all the people on this call. 2 things I'm clear about is all the implementation that continues at historic and record pace. We heard it on the needs for navigation with the plans for the public portal and the Aging Disability Resource Center. For the more services, we heard it with the roadmap partnership. We heard it on affordability with the Medicaid expansions and the insurance commissioners, with the workforce support, with the equity metric. All of those things are, we know implementation is going to continue to make progress. And I'm also just so delighted that the partnerships we have across the cabinet work group were on full display here. We won't do this despite the fabulous, unprecedented Cal HHS leadership. None of us can do this alone. And the leadership and partnership of housing, of labor agency and transportation in particular, but really all across cabinet is why I'm optimistic. But here's the 3 things that are up to this group. State budget, as Liz mentioned, we don't know, do not expect a good year, certainly not a blockbuster year like the past. So state budget is a big uncertain picture right now. I would say federal budget as well. Where is President Biden and our Congress going to go next on building back better and a care economy for all? We can't do this alone. We need the federal government to step up. And the third thing that's uncertain is policy. We heard lots of policy ideas today, ranging from nurse delegation, family caregiver support, perhaps with tax credits, and of course, continued work on affordability. What policies are the legislature and the stakeholders going to want to advance and bring to the governor and work with us all year so that we can get those things signed and moving forward? So love all the information, and I love the clear charge and momentum forward, and lots of questions as we continue to solve this puzzle so all of us have the care we need and deserve in the home we choose throughout our lives. Thank you so much to everyone who made this today possible.
Thank you so much, Kim. Really appreciate your time, and all of our panelists, just remarkable conversations, lots of engagement from our audience. It's been a fantastic session, and I'm really looking forward to getting the recording all situated and sharing that out with everyone. And of course, we'll share it as far and wide as we can, as well as the presentation. Be on the lookout for those. We'll circulate that around to everybody who's registered, certainly everybody who joined us today. Make sure you have those in hand, and I hope you enjoy the rest of your week. And as always, feel free to reach out if you have questions or if there's anything that we can do. Thank you so much.